courses, or even in patients with zero device complication. Thank you.
Thank you, Dr. Ahmed. And now we will just have 5 minutes for discussion. Questions for Dr. Mamoun? Is he around? Dr. Mamoun? Where? Oh, okay. Any questions? Well, I have a technical question. On the first case, a very interesting case, congratulations, but you had the patient in the left lateral position for a thoracotomy, and then you went through a middle line incision for the abdominal part.
Yes.
How'd you manage that?
Well,
I mean, why not an RP approach while you have her on the side?
Semi-rotated rotated chest segment or the thoracic segment, and this is a left lateral fifth intercostal space in a fit, healthy, slim girl. It wasn't that difficult. So the chest is sort of rotated over to the side, and the abdomen is rotated to the other side. It's feasible.
And the midline incision went transperitoneal?
Transperitoneal, yes, yes.
Okay.
And that's because you need to do the rotation.
Okay.
Yeah, it wasn't
right. And you said you oversized the graft. What size did you put in?
14 millimeter.
Okay.
14.
Yeah.
Well,
while I have you on the second presentation, it's of course very nice to do a mini laparotomy for aortic surgery. I think that's feasible for aorta bifemoral bypass. You only need a short segment of the aorta to anastomose, but could you do that for an aneurysm? Have you tried that?
Yes, with 3 of our cases were aneurysms, and it's usually tube graft. And that's when you do an infraumbilical incision, and you pull the incision down, and you can do the distal segment. And in fact, in aneurysm, small aneurysm, it's easier because you're working inside the aneurysm. So the field is the aneurysm once you clamp distally and proximally. And that's one of the tricks, that you use the clamps, the vascular clamps, as retractors. Right. So, you know, they're curved, wily clamps, and they work very well.
Very nice. 2 nice presentations. Any other questions from the floor?
Dr. Mamoun, can you elaborate a little bit on the age of intervention? When do you intervene on those children with mid-aortic syndrome or coarctation? Sometimes they get diagnosed very early, and sometimes a little later. And what is the appropriate age to perform aortic surgery?
Excellent question. Long segment coarctations, unfortunately, most of the time they present with something. And it's usually noticed because of either poor development or incidental measurement of high blood pressure. Presentation with strokes secondary to severe hypertension are not uncommon. To be honest, they should be treated when they're diagnosed, because these are sort of prone to complications from the hypertension. The hypertension is the dangerous element, and they all have hypertension.
Dr. Mamoun, I have also one question about the same topic. So how you choose the length of the implanted graft by children's?
Excellent point. As I said in the presentation, I make it longer, so there's some redundancy to it. So do the proximal and then do the distal, and that shows in the images there is some redundancy. And the reason for the diameter, the 14 diameter in this age group, say between 8 and 12, is sort of, for aortic size, it tends to be adult size, especially for female. But the advantage we get from doing into side anastomosis is very good, and that's, you know, the advantage proximally and distally, because you can have any size graft, and the advantage you get from leaving it long, you leave space for growth. 12% growth in the graft itself happens because of the high blood pressure. So these grafts are they literally grow with the patient. Even if you don't leave them that long, they still have some expansion growth. PTFE, the Dacron grafts, they grow even more with diameter and length.
I think the Dacron generally over 10 years goes by 20. Some people report based on top of Dacron go to up to 30%. PTFE generally does not reach more than 10% over 5 to 10 years. So keep this in mind when you tailor your graft.
I have a question for Dr. Atif Allam. Is he still here? Question is about the feasibility of ultrasound guidance catheterization in patients who are obese or who have atherosclerotic disease or plaque in the orifices of the visceral or renal arteries.
Yes, this is actually a very nice question. Actually, during duplex guided procedure, we have in the abdomen in particular, we have a problem with the gases in the abdomen and the obese patient. But believe me, with experience with the case, good preparation of the patient and advanced modern machines and good expert sonorist, and besides the perfect technique will make the job very easy. I thought before I reject many cases because of obesity in the start of this work, but now we accept what we are able to. As you see, this patient wasn't thin; he was obese and with some fluid, some ascites in the abdomen. But you see the picture is reflecting very clear the castor, the vessel, and the structure of the spleen. So I think I never went for this procedure without my colleague Muhammad Taha. I think he's a professor of radiology. He's one the crucial person in the team. He's just holding the probe, and I complete working with the castor and these things. So if expert person with good nice machine, I'm working in GE 9 machine. It's very powerful machine. And if the technique is perfect, you see the result.
Thank you, Dr. Atif. Any questions for Dr. Amr Abu Rahma?
Another question for Dr. Atif.
Dr. Amr, you perform side-to-side basilic fistula. Why don't you do it from the start end to side? It's a very simple and very popular operation. We do it in Egypt and Cairo University, and superficialization of the basilic vein with end to side to the brachial artery. So as you don't have the hypertension, the venous hypertension is going to happen sooner or later. So why don't you do it from the start end to side, end of the basilic vein to the side of the artery?
Yes, of course, this is the standard, which is end to side. This is a standard procedure. But sometimes you meet a young patient and he has a patent segment in his 4R. So to get benefit from this patent segment, I perform this side-to-side anastomosis.
There is no benefit.
No,
it will not extend except in a very short distance because of the valves.
This very short distance, you may have puncture sites in this very short distance.
The complications are going to be
the complication only is venous hypertension, and it is easily treated with local anesthesia, ligation of the distal limb if it has happened. And
this is what I'm saying to you. You don't do the distal limb from the start.
Yes.
You don't have to do it. You have to do this good fistula with end to side and stop.
We don't argue here there is no venous hypertension. We don't argue there is no, yes, of course there is venous hypertension, and venous hypertension didn't occur in all cases, first. Second, if it occurred, you can easily treat it with simple ligation of the distal limb.
I think here there's a lot of students from Professor Samah Hammam. He was the one who started to do this superficialization of the basilic vein with end to side, and he always instructed us, please don't do it side to side. Do it end to side and ignore the distal segment. This is, I think all the people that knew Professor Samah Hammam have faced this. Ahmed Said, Dr. Ahmed Said, what happens with the professor? Can you elaborate on the cases that you did?
هو يعني فعلا معظم الناس علمتنا ان احنا نعمل الاند تو سايد. I'll continue in English. I would admire any new research to solve problems. Dr. Amr raised a problem that we all face: a young patient who needs longevity of his graft or his access, and we don't have a real answer for this. So he proposed a research that he's trying to make it end to side against the standard, as he said. And he found out that among his patients, 13, I believe, needed the ligation, while the remaining patients didn't need it. So I believe it's just a matter of further research. Maybe if we try to do this more in a research setting, we will have the correct answer. Do we really encourage changing from the standard end-to-side procedure to an end-to-end, side-to-side in especially selected patient or not? I think it deserves a research project.
Okay, thank you, Dr. Ashraf. Thank you, Hamid. Any questions for Dr. Jamal Hubballah? Dr. Munir?
So, Dr. Hubballah, what's the role of thoracic outlet in central venous stenosis and occlusion in AP?
Yeah, that's a very good question. Apparently, there are cases where, and as I mentioned, there are three mechanisms: intrinsic, high flow, and outside compression. So the thoracic outlet syndrome type of situation, compression, falls in that third category, and there have been reports of people requiring procedures like thoracic outlet decompression to relieve that obstruction and maintain that fistula. Absolutely.
Thank you. I have a comment about your presentation. It was an excellent presentation. And you showed us data that the results of angioplasty and surgical bypass are comparable.
This was from one study, yes, correct.
Yes. Well, in our experience, maybe that's true for stenotic lesions, but for total occlusions, we've had really very bad experience with those. They're very difficult to cross, unlike total occlusions in the arterial system. In the venous system, they're usually very tough lesions, very difficult to manipulate. And the ones that we are successful with usually come back within a few months with recurrent occlusion. We've had much better experience with the XX bypass for these patients if you have a patent vein on the other side. This is just our observation and our experience.
Well, I think the paper that I showed had 13 cases that had angioplasty and 13 cases that had bypasses, and it showed that their long-term patency was comparable. Having said that, I think in any of these studies, there is a selection bias. So whatever was selected, this is what the paper showed. Having said that, I mean, I don't think it's a big deal to give puncture that fistula, go up with a wire and see if you can cross it. If you can cross it, and it's a good thing to try an endovascular. Every Kidoki recommendations and all the recommendations tell you that the first thing you try to do is an endovascular approach, as long as you are not burning any bridges. If it works, perfect. How long you get out of it? 2 months, 6 months, 8 months? Most of them, once you cross them, you get a good 8 months to a year and a half. If it doesn't work, then you have to go with the bypass. And I definitely agree with you. The axillo bypass is an excellent bypass. I've done several of them, and I can do them under local anesthesia. And really, under local anesthesia, these are really sick patients, and it works. It lies down perfectly fine, and I think I appreciate your comments 100%.
Thank you very much. Any other questions from the floor? Okay, our last speaker, Dr. Ahmed Khairi. Any questions for Ahmed Khairi? Dr. Ashraf?
You are giving a good trial for some of the problem that is very nasty. But synthetic graft for the lower limb in an immunocompromised patient with infections is going to lead to amputation. The infection is going to end by amputation. So I cannot argue what you are doing, but did you face cases with infection and you had to amputate?
Thank you, dear Professor, for your comment. First, the complication rate regarding the infection for synthetic graft for dialysis in upper limb and lower limb in meta-analysis and comparative trials were comparable or equivalent, no different, no significant difference. And we know that what prevents us to implant synthetic graft in lower limb for dialysis patient who is immunocompromised, and we did in upper limb, which is also he is immunocompromised. This is first point. Second point, what gave us the idea about this trial was the initial experience with lower limb dialysis access with synthetic graft in loop pattern. We found that infection was the most common cause of graft thrombosis, and when we explant the graft, we should ligate the inflow and outflow, which end with a serious complication like amputation, as you said, my dear professor. We started to move the inflow downward through the femoropopliteal segment, aiming to make growing exposure limited time, as we did only single anastomosis. Second, when we move downward towards femoropopliteal segment, we assumed that when we are going to ligate the infected graft, we might not have any serious complication, as the chronic steal phenomena of the implanted graft will induce chronic ischemic status in those patients and allow collateral circulation to maintain circulation enough to distal, which was we noticed in our case series study. So in our result, we didn't found limb threatening condition in those patients in whom we are obliged to ligate and explant the infected graft.
Thank you, Ahmed. Just a quick comment about the risk of infection. If you do decide to do your access in the lower limbs, then one of the options that you can consider is superficial femoral vein transposition and superficialization. It's an autogenous vein, you don't need synthetic graft. I think it's a good procedure that's probably being underutilized if you do decide to go down to the lower limbs. I think we have to end this session because of...
Can I answer, please?
Right.
We did femoral vein transposition, and we found this is an extensive procedure with prolonged time of exposure due to we obliged to ligate tributaries of femoral vein. The prolonged time of exposure, as we know as a vascular surgeon, one of the main risk factors for infection, and also it was published in several trials. The main cause of infection in this patient was the prolonged duration time. Thank you.
Okay. We have to end this session, and we have just one announcement. There will be a prize context at the end of the following session. So the company is encouraging you to